during the TIL therapy, we first do the tumor resection. It's called harvest. It's a simple small surgery when we take the tumor out. And then we send the tumor to the pharmaceutical company where it's performed as a central manufacturing. And over a 3-week period, there is a manufacturing of a TIL, but it takes additional around 2 to 3 weeks to do the quality check. And around 6-week interval is when we receive the cells and we are able to administer those cells after chemotherapy. I think it is very unique because this is one-time treatment. And of course, if it works, it completely changes quality of life because as a patient, they don't get any new treatments or any other follow-ups, any treatments other than just scans for physical and reviewing, ensuring no delayed side effects. But overall, it's very different because it's just a one-time of treatment and just a follow-up with scans if no disease progression, So it's very lovely because it's a different quality of life. You know that you have advanced stage 4 disease, but you have been treated with something that you no longer require any treatment. This is like completely different feeling from other therapies. Yeah, I think it's very important that patients know about this treatment and they get to see someone who is specialized in this treatment so they can provide them in details what to expect. Like some side effects everybody develops, like most people. Like if you get interleukin-2, you will develop some rigors, but realizing that those rigors actually last only short term, and there are medications to help with that, and this is a very short lasting side effect, and many other side effects, those are important to appreciate. I would say it's really important to get to see a physician who is specialized in this and learn when it's indicated, what are the side effects, and how to go through. It's an important thing. I think it's still very doable because we often keep the local oncologists and work with them, but also in the clinic we follow up and we check we do the vital organ testing and we prepare the patient. But it's important to realize that the treatment duration in itself is short, and during the treatment you will be at the hospital, and regardless you're traveling within state, outside of state, out of country, it's just certain duration. Usually if chemotherapy is also administered in patient, it's around 14 days. So you will stay in the hospital, but once you're discharged, you will stay in certain proximity for some time. In our institution, we actually decreased that amount because most of us, we adopted from CAR-T. We say to stay up to 30 days locally, but we changed in our institution because we realized that patients really do not need that. A lot of them are really healthy and no longer need any care after day plus 14. So we changed to up to day plus 14. So as long as there is some help, and a lot of the times also Iovance helps if you're traveling certain distances and it's very far. I know that they also help. So they can stay here over some period of time, but that is not a commitment that you have to come here daily, weekly, This is a treatment for some period and you commit to that and you complete it, and then it's very flexible because if you respond to therapy, you only come every 3 months or to come and have scans and have adverse event check, and rest we can always work with local oncologists. One other important thing is, I think, for both patients and providers, we often think about TIL that is a therapy associated with high risk of adverse event, especially during inpatient hospitalization. But it's important to acknowledge that these are side effects that are present during the initial hospitalization. And if you are really in a good cancer center and they know how to treat patients, there is much less likelihood of patients developing those toxicities, at least severe toxicities. And so, thinking that this is a treatment that you consider as a last resort, like a last one because it's too toxic, I think it's a wrong decision because it's actually opposite. When patients come, they are very functional and they have low burden of a disease. They tend to tolerate the therapy better and they tend to respond. So that's why I would say actually opposite. If patients already tried one first-line therapy and they did not respond and that treatment did not work for them, then I would consider this therapy right away because it's a one-time treatment and you will see whether it's working or not, and then you can move to the rest of the therapies. But again, thinking that this is last treatment because it has side effects or it's more commitment is actually not true because it's only small duration of therapy. And I think it's a less commitment because you're not going to treatment center every month to get some infusion or oral medication. And again, we do have a lot of trials have demonstrated that low burden of a disease and functional status, all of these things are important for successful therapy. The clinical trial is right now ongoing for first-line therapy with pembrolizumab. A lot of centers do not participate because we don't think pembrolizumab is the right control arm because a lot of us do provide combination therapy at the moment. I would say, my personal opinion, again, there is nothing right or wrong. I think if I had melanoma, like I would probably choose to do the combination immunotherapy first. And if the combination immunotherapy does not work, then I would proceed with TIL therapy. Because in comparison to the fact that you're getting lymphodepletion and chemotherapy, which especially for young people may have some long-term side effects. So I think it's reasonable to consider first-line therapy. But again, if you tried combination first-line and if it does not work, then it's very reasonable to proceed with TIL.